My name is Alex Murray and I'm the clinical lead for the burns unit at Stoke Mandeville. This is Sarah Atkins and she's the clinical lead for the burns facility at the John Radcliffe in Oxford. And this is Debbie Turvey, who's the burns unit sister at Stoke Mandeville.
So Alex and I and our two trusts, we work together as one service to provide burns care for the people of Oxfordshire, Buckinghamshire and the surrounding counties. So if you're referring a patient to us, this video is applicable for all of those people.
Good first aid and wound care are essential to achieve good outcomes in burns care, and this video will guide you through that process.
No matter what the cause of the burn, 20 minutes of cooling with water is essential. This decreases the depth of the burn, it decreases the pain from the burn, and we know that it increases the clinical outcome from the burn itself. So if your patient hasn't had water cooling or insufficient amount of time, please make sure that you put the burnt area of the patient underneath the cool running tap. So for instance, on an arm, while keeping the rest of the patient warm, you could put the arm underneath the tap. If there is any concern that there may be a chemical burn element to the burn, please continue to irrigate with water for longer, either until the pain that the patient experiencing has gone, or by doing a pH test and seeing that the pH is neutralised to a pH of 7. So this is an example of the pH indicator strip test that we use. This is the area that you put on the skin. So for example, like so. And then the strip will highlight depending on whether it's an acid or an alkali, and you want to irrigate the burn until you get to pH of 7.
To get ready for the burn debridement and dressing, first give the patient adequate analgesia, adhere to your local unit policy, and we will give advice in an attachment. It is good to get everything ready, and this is what we need. First of all, open up a blue towel, then get out your dressing pack, including scissors and also some forceps. We use aqueous chlorhexidine for cleaning the burn, but you can also use sterile saline. Make sure not to confuse this with the alcoholic chlorhexidine solution, which would be very stingy. Next is the non-adherent dressing, and in this case Mepitel, which is excellent as it is silicone based and does not stick to the burn wound. The secondary dressing on top of the Mepitel includes gauze, and then on top of this, depending on where the burn wound is, you can either use tape such as Mefix, or on a limb use a crepe bandage to secure the dressing in place. So Debbie is going to start by removing any residual loose skin. This is often in the form of a blister, or the blister may already be popped. Note that Debbie is wearing sterile gloves. The wound is then cleaned by wiping carefully with a chlorhexidine or saline soaked gauze, or blisters are snipped using the scissors if needed. It is important to wipe the burn wound with the solution and make sure that all the debris, dirt or loose skin is removed. So having seen an example of a mid-depth burn, we would like to show you the 5 specific types of burn wound depth, and also it's important to remember that these can occur within the same burn wound. So first of all, starting with simple erythema, for instance in sunburn, this is painful but the skin is intact and there are no blisters. The next level of depth is superficial partial thickness, where we start to see blisters and this is extremely painful with good capillary refill. This injury has to be included in our total body surface area assessment. Moving on to mid-partial, as we've already seen in our patient today, here the capillary refill is sluggish and the burn wound is partially sensate but not as painful as in the case of superficial. In the deep partial thickness burn, there is often fixed staining in the dermis, which is not to be confused with the redness seen in a superficial burn. Here the burn wound will be almost completely insensate, and it is therefore at the point that surgical intervention may be required. Finally, the full thickness burn, which is often leathery in appearance due to the eschar, is completely insensate and has absolutely no capillary refill. The burn wound will then need a dressing, unless it is a superficial burn of the face, in which case something simple such as Vaseline is sufficient. To keep things simple with the primary dressing, we would first advise putting on Mepitel, which is a non-adherent silicone-based layer. This is good because it does not stick to the burn and is comfortable. The next layer after this, in our burns unit here, we use a silver-based dressing, but in A&E, MIU or in GP practice, it is fine to use the simple non-adherent layer. On top of this, we will use a gauze, and this will allow for any fluid to be absorbed whilst also keeping the burn wound moist and providing comfort. Finally, we'll put a layer on top, which, depending on where the burn wound is, could be something like Mefix, but in the case of a limb burn, the dressing should be secured with a crepe bandage, and this is put on using a figure-of-8 pattern and should be snug but not too tight. Secure this with some tape and make sure that the patient is comfortable. You can also use a double tubey grip over the top of this to help keep the bandage in place. Finally, it is important to remember to advise the patient to take regular pain relief, including paracetamol and ibuprofen. If the burn is included on a limb, then it's really important the patient keeps that limb elevated for the first few days as much as possible, and that you also warn the patient to look out for signs of infection, which could include increasing pain, temperature, or feeling generally unwell. If that is the case, then they need to get in touch with us as the burn service.
And if you would like to feed back to us or to ask us any questions, please call us if it is urgent, or use the emails that we will provide for non-urgent comments. Thank you for listening.